Hi everybody. It's a great pleasure to be here. I thank the organizer for inviting me. I will talk about POLR3-related or 4H leukodystrophy. So I have no relevant disclosure to this presentation, but I've been involved in some family foundations as a member or as a chair, and I've had a different they had different compensation for traveling and consultant for Passage Bay Bio, and I've had some grants from pharma as well to do clinical trials. So I'm going to talk to you about POLR3-related leukodystrophy or 4H leukodystrophy. 4H stands for hypomyelination, hypodontia, and hypogonadotropic hypogonadism. It's an autosomal recessive disorder. So a little bit of the history of this disease. A variant of the disease was described first in 2003 and was called leukodystrophy with oligodontia. In 2005, Dr. Wolf et al. Described ataxia with delayed dentition and hypomyelination. In 2006, Simon et al. Described 4H syndrome. In 2009, there's a Japanese group who described the disorder and described it. They gave them the name as per the MRI features of the disease, and they called it hypomyelination with cerebellar atrophy and hypoplasia of the corpus callosum. In 2010, my group described the disorder and we called it tremor ataxia with central hypomyelination. In 2011, my group discovered the first two genes causing this disorder, POLR3A and POLR3B. In 2014, with Dr. Wolf and numerous international collaborators, we looked at the clinical spectrum of 105 cases with POLR3A and POLR3B mutations. In 2013, my group found the third causal genes for POLR3-related leukodystrophy, and we started to understand the first insight into pathophysiology. In 2018, there's another group who found the POLR3K as a rare cause for 4H leukodystrophy. And in 2019, together with Dr. Wolf, we published the clinical spectrum of the disease for patients with POLR1C mutations. So the epidemiology of the disease, the incidence and the prevalence are unknown. There is, however, a paper from Dr. Van der Veer's group about the frequency of the different leukodystrophies based on a cohort of more than 49,000 exomes. And in this series, 4H leukodystrophy represented about 5% of all leukodystrophies, and if you can see here, adrenoleukodystrophy is about 15%, MLD 10%, AGS 10%, and vanishing white matter and 4H are equal at position 8 and 9 for with about 5% of the cases. So the typical clinical presentation, patients present as toddlers with motor delay or motor regression. And then they have a relatively slow progression of the disease. We have other kids that present a little bit later in life, typically after 10 years old, and these kids would present with learning difficulties, intellectual disability, and cognitive regression, and will develop the motor features later. Very recently, though, we realized that there was a very severe form of the disease with an onset in between 1 and 3 months of age, severe global developmental delay and regression, acquired microcephaly, severe dysphagia, and failure to thrive. And then, incidentally, we have found patients that had MRI of the brains for other reason than regression, and they because for seizures, for example, or an optic neuritis, and they were found to have hypomyelination and mutation in POLR3B. So I've put on the left normal MRI. So if you look at the typical MRI for 4H, sagittal T1, you see a thin corpus callosum. There's a proportion of patients that also have cerebellar atrophy. It's more common in patients with POLR3b mutation compared to POLR3a mutations. And then you see diffuse hypomyelination with preservation and T2 hypointensities of specific region. So the dentate nuclei, the anterolateral nucleus of the thalamus, the globus pallidus. In some patients, there's a dot of preserved myelination of the corticospinal tract at the level of the internal capsule and the optic radiations. So the mild patients that we uncovered had normal corpus callosum or very slightly mild, like mild thinning of the corpus callosum. Their cerebellum was preserved, and as you can see, they had more myelin in the posterior fossa. They also had myelin more than like in the posterior aspect of the splenium of the corpus callosum. They also had myelin throughout the internal capsule, and not just the optic radiation, but the fibers around it and the occipital poles. And as you can see, if you go higher up, there's also preservation of myelination in the corticospinal tract. The more severe patients had more of a neuronal type MRI with some significant cerebral atrophy. These kids also have, as I said before, progressive microcephaly. There is involvement here on the dentate nucleus and the posterior pons, and there is atrophy of the thalami and the basal ganglia with hypersignal intensity of the putamen on both sides. So signs and symptoms by organ. So neurological features. What predominates is cerebellar features, so ataxia, dysarthria, and dysmetria. Pyramidal features are often seen as well. They're often more predominant in the lower extremities, but they usually are not the predominant features. Extrapyramidal features are very common, especially dystonia. In most patients, it's not something that require treatment, however. And that dysphagia is also a sign that you see in these patients. It's probably at least partly a cerebellar type dysphagia. It's quite unpredictable. Some patients can be able to eat some things in the morning, for example, but then when they're tired, they have more difficulty eating, and they can choke on food. So it's something that needs to be well taken care of. The non-neurological features, so myopia is almost universal. It's present in the vast majority of patients, and it usually progresses over several years. So we recommend that these patients are followed by ophthalmology every 6 months to adjust their glasses. And most patients will develop a high level myopia. Dental abnormalities are also common, but not universal. There's variable type of dental abnormalities, including hypodontia, oligodontia. Some patients have neonatal teeth. There are abnormal shapes of the teeth, abnormal colors, etc. Endocrine manifestations are also common, but not universal. The typical and the most common endocrine abnormality is hypogonadotropic hypogonadism. There's about 50% of patients who have short stature, some of which have been tested for growth hormone deficiency and had growth hormone deficiencies, others did not. The vast majority of patients, we just reviewed, published a case series of 150 patients with 4H and endocrine manifestation, and so the vast majority of patients with short stature did not get tested for growth hormone deficiency. We also found some patients with thyroid functions abnormalities, and so this highlights that the endocrine manifestations are not only delayed puberty or arrested puberty caused by hypogonadotropic hypogonadism. So the diagnosis is made by gene panels or whole exome or genome sequencing. And the disease is caused by biologic mutations in POLR3A and POLR3b, which we uncovered in 2011. and then to POLR1C and POLR3K, as I said before. So not to be forgotten that there are other phenotypes that do not have a leukodystrophy. So autosomal recessive mutations in POLR1C are also associated with Treacher-Collins syndrome. And there is some overlap between Treacher-Collins syndrome and POLR3-related leukodystrophy. There are some patients with POLR1C mutation that also have Treacher-Collins that also have typical Treacher-Collins phenotype, but there's also patients that have POLR1C mutation that have some milder craniofacial features. There are cases of neonatal progeria that are caused by specific biallelic POLR3A mutations. Some of these patients also have a leukodystrophy, but some don't. And finally, there are patients with spastic ataxia or dystonia or a diagnosis of a hereditary spastic paralysis that have been shown to be caused by mutations in POLR3A or POLR3B. So, as a refresher, we had Dr. Wolf talk about the tRNA synthetases disorder. POLR3 actually is a protein complex important for transcription. So there are three types of RNA polymerases. They're named 1, 2, and 3, and they're responsible for the transcription of DNA into RNA. POLR3 is a 17 subunit complex, with POLR3A and POLR3B being the largest subunits of the polymerase and forming the catalytic pore of the polymerase where the DNA enters to get transcribed into RNA. POLR1C is a common subunit to both POLR1 and POLR3, and POLR3K, as you see, is here. POLR3 is responsible for the transcription of small non-coding RNA. So it's responsible for transcription of all tRNAs, the RNA 7SL, which is important for the insertion of protein into membranes, the RNA 7SK, LU, and D2 elements, which are important for the transcription of POL2, the ribosomal subunit 5S gene, which is important for cytoplasmic and mitochondrial translation, and the vault RNAs, which are important for transportation of the messenger RNA from the nucleus to the cytoplasm. So what we've been able to demonstrate in the last few years is that mutations encoding a subunit of the RNA polymerase 3 either are hypomorphic, so they can cause either the decreased amount of a specific subunit produced, an abnormal assembly of the complex, or an abnormal interaction of the complex with the DNA. And then the result of all this is a reduced capacity of transcription and later translation. There is no patients like in the vanishing white matter disease genes. There's no patient with two mutations stop because it's an ubiquitously expressed proteins, and it's embryologically lethal to have two stops. The general pathophysiological hypothesis is that the hyperfunctional POLR3 complex leads to insufficient transcription during critical developmental milestone. So during myelination, it is unclear why patients get hypomyelination and specific involvement of other organs such as the teeth or the pituitary gland. The supportive care and anticipatory guidance for this disorder, I think it's well explained in the revised consensus statement of on the preventive and symptomatic care for patients with leukodystrophies. But as a general rule, you would treat the symptoms that bothers the patient. So the dystonia, if it's problematic functionally or if it causes pain, spasticity, cyalloria, etc. Prevention of fall is very important because, of course, if these patients get fractures in their legs and they get immobilized for several weeks, it may be difficult for them to get back to walking. Dysphagia is important, as I said before, to manage properly to avoid aspiration, chronic lung disease, but also choking on food. And then bone health is also very important. So for patients that are wheelchair bound, it's important to have verticalization with standing frames or walkers, etc. So these were just examples of general supportive care. There's many other things that can be done for these patients. And then organ-specific supportive care. Of course, these patients need to be followed regularly by a neurologist. They need a rehab doctor and a rehab team. The ophthalmologist I talked about earlier, we usually recommend every 6 months to adjust their glasses. The endocrinologist should be involved early on. I don't think we should wait until puberty, because now we've demonstrated that some endocrine abnormality can have happened before. It's important for these kids to be seen by the dentist and orthodontist as needed if they have teeth abnormalities. Unfortunately, at this point, there's no disease-modifying therapies for this disease. And if we summarize, 4-H leukodystrophy or POLR3-related leukodystrophy is typically present in early childhood with motor delay or regression, and the predominant features are cerebellar involvement with some pyramidal signs and dystonia in most patients. It's an autosomal recessive disease caused by mutations in POLR3A, POLR3B, and POLR1C. The disease spectrum is expanding every year with the new disorders described, the severe infantile form described earlier this year, and now the recognition that there are also very mild patients, adult patients affected. There's no biochemical or associated laboratory findings. The key features on MRI are diffuse hypomyelination with increased T2 signal of the dentate nucleus, the optic radiation, the anterolateral nucleus of the thalamus, the globus pallidus, and the corticospinal tract, and the posterior limb of the internal capsule in some patients. The treatment is supportive, and as I said before, it's important for these patients to be followed by a multidisciplinary team. Just want to thank the patients and their families for their participation in our research program, all the collaborators internationally, without which we wouldn't be able to do all of these clinical descriptions. The Montreal team for leukodystrophy, and then the international collaborators. And I really want to highlight the collaboration with Nicole Wolf for all of the clinical characterizations of 4-H, which we've co-lead throughout the years. And then my graduate students, and my research staff, and the funding we had over the years. Thank you.
Thank you, Dr. Bernard, for a beautiful talk. Let's give it a moment to see if there are any questions.
Genevieve, this is Eileen Vandiver. I think a key question is sometimes how you address family concerns about pubertal development and hormone replacement, and how you parse that out, in the context of the variable developmental abilities of those individuals. Do you mind? Because I think that's a question I've grappled with before, and I think it's good for the audience to hear how you think about it as they interact with their endocrinologist. Because I think the temptation is, of course, to replace, missing sex-related hormones. But I'd love to hear your up-to-date thoughts on when and how.
Thank you. That's a great question for which we don't have the perfect answer. I think it's important to it's an individualized decision. The pros of treating are especially bone health. and appearance for the kids that have a milder disease, and that socially could be embarrassed because of the absence of puberty. The cons are is mainly related to growth spurt, I would say. So if you have like a growth spurt by giving hormone replacement for delayed or absent puberty, you will have a growth spurt, and then you will become more clumsy. And then if you're about to lose ambulation because your gait has regressed over the years, there's a chance you won't be able to walk again. So I think that's the thing that we're concerned about mainly when we start hormone replacement for these patients. And I've heard some history of patients that regressed with hormone replacement, but we weren't able to look at. We did. This is not something we found in the cohort of patients that we looked at. Some of the patients, though, did not tolerate the hormone replacement. I don't know if your experience or Dr. Wolf's experience is different.
No, I mean, I think as you said, it's a very individualized decision, and I think it's just important to pause and think about it before deciding to treat. I do worry a lot about how poorly we understand the effects of puberty on the secondary axonal injury in some of these hypomyelinating conditions, because I feel like across that spectrum we see some decline in the teenage years that we don't fully understand. So I second your thoughts. But thank you.